Hi, this is Courtney Deitch with Honeysuckle and Pearl of Lake Charles, Louisiana, and I want to talk about tongue ties. I feel like we're seeing so many tongue ties these days in babies. What's the reason? I don't know. Epigenetics, our environment, is it jaws are shrinking the past 100 years. If you look at a skull from 100 years ago to now, jaws are shrinking. We don't have room for our wisdom teeth. Wisdom teeth are having to be removed. So we're just seeing a lot more tongue ties and moms with issues. So in my office, I see a lot of moms that come in with painful latch, bleeding nipples, and there's just so many things. So you can have all the symptoms or none of the symptoms, or a few of the symptoms. Obviously, you're going to have symptoms, and baby's going to have some symptoms, but you don't have to have every single one of these symptoms. But some of the things I see, a lot of times I see that recessed chin. Mom comes in and says, "Oh my goodness, my baby looks like he has an overbite." So it's not an actual overbite. It's that posterior tongue tie pulling that chin back and makes them look like they have an overbite, but it's not an actual overbite. There's exercises we can do for that and things we can do to help facilitate moving that jaw forward, which we work on. A lot of times it looks like babies don't have any lips, so they just real small lips, pursed lips, and that is usually has to do with a lip tie. Babies have a hard time staying latched. So they'll get them latched on and you think you're doing great, and then all of a sudden babies pop off and you have to restart that whole process. And it's very frustrating for parents. But sometimes babies just cannot stay latched. One of the controversies in our profession is flange lips or don't flange lips. So I always do a case-by-case basis. Some babies you can help facilitate flange those lips to get those lips really wide like we want them. And other times they are compensating and that jaw's so recessed they just can't stay attached if we are pulling their lips up. So that's definitely a case-by-case basis. But some babies just are unable to get that big gape and lips all the way flanged out, bottom and top. So they have a hard time, so they come off. One of my main things is mouth breathing. So we do not want babies mouth breathing. So when they fall asleep, some of it can be positional. When they fall asleep like this, their mouth comes open. And we want to make sure to shut that mouth because we want the tongue sitting at the roof of the mouth. The roof of the mouth is developed by the tongue sitting on there, that palate. So babies that have a high palate, usually their tongue cannot sit at the roof of the mouth or just the tip of that tongue sitting on the roof of the mouth. And that causes a high palate, and that has to do with tongue ties. So if you reach your finger in your baby's mouth and that palate is super high, we need to facilitate getting that tongue at the roof of the mouth to shape that palate. And things that happen later on with that, if that palate stays high, is palate expanders. So you probably know a lot of children had to have palate expanders and braces, and that's because their tongue, even as adults, our tongue should be sitting at the roof of the mouth. The whole thing, not just the tip. Gassy, swallowing air, clicking, noisy babies, gulping. You hear that when they're eating, that's at the breast or a bottle. Babies just get really noisy, and they're usually sucking in air when that happens. When they're sucking in air, if we don't get that up, it goes down, and we're going to have gassy, fussy babies. There's some exercises we can do to help relieve some of that gas, but a lot of times it causes reflux. So reflux can be spitting up where it comes out, or reflux can just be, you can hear it in babies. It comes up and they swallow it back down. It comes up and they swallow it back down. So it's not coming out. So babies may be gaining weight just fine because they're swallowing that reflux right back down. One of the symptoms we have when we see that is nasal congestion. You think, oh no, my baby's sick. Usually babies aren't sick. That is milk up in that nasal cavity being stuck up there from refluxing. So tongue motility has a lot to do Tongue mobility has a lot to do with gut motility. So babies that their tongue doesn't function very well, a lot of times they have some gut issues that we're dealing with. And that comes out as reflux and gas. Fussy babies. Poor mamas of tongue-tied babies are usually very tired because babies are very fussy. Body tension. A lot, what I see a lot of times, babies come and they're like this. They look like they have no neck. So you want to see, does my baby look like they have no neck and these shoulders are really high? So babies can't nurse well in extension when they're like this. They're usually trying to nurse in flexion, which all babies, we want relaxed shoulders and nursing in extension. So I see that a lot of times. There's some exercises we can do, but for those babies, really they need professional body work with somebody that specializes in infant care. So that's super important for that. So it's not just tongue tie is not just we go in and we do a procedure at all. There's so many things to think about. We want to do exercises in the mouth. We want that tongue getting functioning. Do we always need a tongue tie release? No, definitely not. Sometimes we just have tension in that mouth that needs to be stretched out, and moms need to know, hey, what can I do to facilitate this? Now, if we've been doing stretches 2 or 3 weeks and doing exercises and things to facilitate that, and baby's symptoms are no better, do we want to consider getting a release by a provider that is really good? Yes. Yes. I'm not going to really talk about that, but there's different types of releases, and I have some that I personally prefer over others, but it has a lot to do with how that provider is with the tongue tie release. And a lot of times we need to do tongue, lip, and cheeks. Cheeks have a lot to do with function in that big open mouth gate. They have a lot more to do than you think. Some babies have no cheek tension and others have quite a bit. So that's something that we're definitely looking for when assessing a baby. I like to do a functional assessment. How is baby functioning? Not just anatomy. So it's a combination of anatomy, function, and symptoms. So it's kind of all three wrapped into one. It's a functional assessment on how baby's actually functioning. Because do you want to fix it if we see it, but baby's functioning just fine? No, definitely not. We want to do what's best for mom and best for baby, but we do want baby highly, highly functioning. A lot of babies are always hungry. They just seem hungry because they're unable to transfer milk. Sometimes they can't transfer at breast. Sometimes I had a mom the other day said baby takes an hour to eat one bottle, and then it's time for her to eat again. They can barely get enough in, which then, of course, has to do with baby weight gain. And babies don't gain enough weight. They're spending a lot more energy trying to eat than they are actually getting calories. So that's when we see weight problems. But weight problems do not always have to do with tongue ties. Some moms have big letdowns and baby can get that milk super fast and baby is gaining weight, but that doesn't mean they're functioning. They might have a lot of compensations that they're using to just be able to gain that weight. So a lot of providers think if baby's gaining weight, we don't need to deal with that. But they don't see moms with sore nipples, bleeding nipples, unable to breastfeed, baby unable to sleep, colicky, fussy, screaming for hours. All those things need to be addressed. Mouth breathing, super big, airway. All that's airway. We want that tongue resting at the top of the mouth. If I could preach that, that's the main thing. We want to make sure that baby has appropriate tongue posture. If babies have ineffective milk removal, that affects supply, and then we're lowering supply because baby's not emptying breast. So mom's then going to have a supply problem if we're not doing something to correct that. While we're working on getting baby functioning, we also have to make sure to keep mom's supply up. So it's we need to do both those things at one time. And when babies are ineffectively nursing, a lot of times they get clogged ducts and mastitis repetitively. So that's something we have to address, is clogged ducts and mastitis. And I'm not going to go into that because I have a whole nother thing I could talk forever about with clogged ducts and mastitis. But today we're just going to talk about tongue tie. Any kind of struggling to feed. It could be at breast, it could be at bottle. So what if mom's bottle feeding and they're not breastfeeding? Because mom chose not to, or baby was unable to. Do we still want to address the tongue tie? I say yes. Always we want to address it if baby is struggling feeding, struggling breathing. What are some things like later on in life that could happen if we don't address it? maybe nothing. I mean, I don't have a crystal ball. I can't say that for sure we will have problems later on, but potentially you could have a speech problem. More than often, I see babies closer to that 6 months to a year when they're trying to eat and the tongue tie has not been addressed. They're trying to eat solid foods and they're just unable to do that. They're choking, they're picky eaters, they're only able to eat super soft foods. They're not able to, as they get older, really chew. And what they're doing is they're just protecting that airway because they have airway issues. And so it's not that they're a picky eater. They just, you go, oh my goodness, my child only wants to eat French fries and chicken nuggets. Well, those melt in the mouth, and that is an airway protection mechanism in there that they want to just eat those Cheetos that dissolve in their mouth. So that's something that can happen later on. We talked about orthodontics. If that palate is not wide, then palate expanders. One of the things also that I see a lot with is like cavities, because we use, if you think about it, you use your tongue after you eat to clean your teeth. So we use our tongue. If baby's tongue isn't able to lateralize or move side to side, then you cannot clean those teeth. So sometimes they'll end up with cavities more than other children. Some of those may happen, but none of them may happen. So I like to say if babies are struggling eating or mouth breathing, airway issues, then it's something that really needs to be addressed. A couple other signs we look for are sucking blisters right here on the top of the lip, and babies leak milk. So if you're soaking wet after you nurse your baby, or your lap soaking wet after giving a baby a bottle, babies leak milk when they have poor oral function. So that's kind of what I see in my practice and what I see for mamas and babies, and I definitely love to help you through this. So give me a call if you have any questions or want to discuss it, or visit my website, honeysuckleandpearl.com, and fill out the form. Even if you're not local, I do virtual visits and virtual consults on tongue tie, and poor oral function, and we can work through it. Thank you.